partnerships and high brand satisfaction. And as we prepare to review CPT code changes, we know many healthcare providers are concerned about disruption to the revenue cycle. Changes in coding rules and guidance may disrupt the revenue cycle. So reviewing the changes supports an uninterrupted revenue cycle. And now let's get started to look at CPT changes for 2023. Here's what we plan to achieve today. Identify those 2023 guidelines and code changes across the various surgical sections. Explain abdominal hernia, the new codes, definitions, and guideline changes, as well as look at the COVID-19 vaccinations and the evaluation and management section guidelines. So let's start with the numbers. There's a total of 393 changes overall, with 225 added codes, 75 deleted, and 93 revised. In addition to code changes, there were multiple guideline revisions and additions. We won't be able to go over all of the updates in this time, but we have selected the most relevant areas to share with all of you. So let's get started with neurosurgery. There were technical corrections from the 2022 CPT update that were corrected in 2023 books as shown here on the slide. These edits will not be reflected in the 2023 code set as revised, since the changes were the intended presentation of the content in 2022. These corrections are as follows. Codes 22630 and 22633 were revised to reflect being a parent code to the add-on codes 22632 and 22634, respectively. The title revisions now also includes lumbar for those codes. 22634 was revised to clarify the code is intended to be reported for each additional interspace and includes vertebral segment terminology. Codes 63035 and 63044 were also revised to include the vertebral segments. Guideline clarifications for reporting a decompression on the same vertebral segment as a posterior interbody fusion were part of the technical corrections. Again, it is important to note that the corrections are not reflected as changes in the book. So now let's look at changes for 2023, starting with the total disc arthroplasty. Total disc arthroplasty is when the damaged intervertebral disc is removed and replaced with an implanted artificial disc. The goal is to alleviate the pain and pressure by restoring the natural spinal disc structure. Cervical and lumbar spine are common sites for this procedure. As there may be multiple disc space requiring an implant, code 226860 has been added for when a second lumbar disc is replaced. This new code aligns with the code pattern for total disc arthroplasty of the cervical spine. Note, if more than two interspaces are treated, the unlisted code 22899 is reported for the entire procedure. Other related changes are the deletion of the add-on code 0163T and its associated parenthetical notes. Code 0163T was used to report a second interspace total disc arthroplasty of the lumbar spine. This code is deleted as the Category 1 replaces the Category 3. And code 22857, the parenthetical notes were revised to note the changes in codes for proper reporting. Next, we will review changes related to the sacroiliac joint. A sacroiliac joint arthrodesis is used to treat various conditions such as the facet joint syndrome, degenerative joint disease, or other sacroiliac joint pain by fusing the joint. New and revised introductory guidelines and notes are available starting at code 27279. These changes provide information on the appropriate use of the new and revised codes related to arthrodesis of the sacroiliac joint. A new T code 0775T was created to identify a percutaneous approach for placing an intra-articular stabilization implant at the sacroiliac joint. Code 27279 was revised to indicate placement of transfixing device. The transfixing device is an internal fixation device that passes through the ilium into the sacrum, thus transfixing the sacroiliac joint. Code 27280 was revised to distinguish that the arthrodesis procedure was performed via an open approach. Other new T codes are seen on the next slide. The code 0719T is for when damaged facet joints are replaced with artificial facet joints via a posterior approach. The parenthetical notes for this code provides guidance on what procedures are included and therefore not separately reportable as shown on the slide. The new code allows for tracking of how often the procedure is performed. Another new T code is add-on code 0735T. This code is reported for the preparation of the cavity left once a brain tumor is removed and a radiation therapy applicator is placed. The applicator is balloon-shaped and used to insert a single dose of radiation directly at the tumor bed at the time of tumor removal. This code is reported in conjunction with the appropriate craniotomy code. And next, we will look at changes to nerve injections. These procedures may also be known as nerve block, typically performed for pain management. Changes to these codes identify when image guidance is included with the nerve injection procedure and when the imaging may be separately reported. The image guidance includes ultrasound, fluoroscopy, or a computed tomography or CT. This slide shows which codes allow for separate reporting and which codes indicate imaging is included. And next we will review cardiology. A few areas to bring attention to are the endovascular pulmonary arterial revascularization, percutaneous creation of AV fistula, and coronary lithotripsy. Let's start with the pulmonary artery revascularization. This procedure is used to treat pulmonary artery stenosis. Pulmonary artery stenosis causes an increase in right ventricular pressure that can lead to right-sided heart failure over time, especially if untreated. Common symptoms are shortness of breath, fatigue, rapid breathing or heart rate, and cyanosis. Pulmonary artery stenosis can be either congenital or acquired. Congenital pulmonary artery stenosis may occur in patients with congenital heart disease, such as atrial septal defect or pulmonary atresia. Stents are placed into the pulmonary artery and they provide a rigid framework for vessel support. And we will look at the 5 new codes on the next slide. Here you will see the new codes for reporting of the endovascular revascularization stent placement. The codes represent the catheterization efforts to reach the obstructed pulmonary vessels. They are differentiated by normal versus abnormal vessel connections, along with laterality, unilateral versus bilateral. Code 33900 through 33901 represent normal native connections. Normal native connections are considered superior vena cava, inferior vena cava to the right atrium, then right ventricle, and then the pulmonary artery. 33902 and 33903 represent abnormal connections. Abnormal connections include post-surgical shunts that are pathways, such as the Baylock-Toxin shunt. And the add-on code 33904, it is an add-on code for the additional vessels or separate lesions, regardless of the type of connection, whether it is a normal or abnormal. The parenthetical notes containing guidance on what services and situations are not separately reportable, along with they are separately reportable. So for example, a balloon angioplasty performed in a separate artery or for a lesion different from the lesion receiving the stent are separately reportable. This slide also shows services which are included and not separately reportable. Please review the notes for additional details. And next we will look at changes to pulmonary angiography. Prior to 2023, the CPT code set did not include a specific CPT code to report angiography of major aortopulmonary collateral arteries, or abbreviated as MAPCAs, when performed during cardiac catheterization procedures. Add-on codes 93569 and codes 93573 through 93575 were established to allow proper reporting of angiography of the pulmonary arteries, the pulmonary veins, and the MAPCAs when performed during cardiac catheterization procedures. The parenthetical guidance at the start of the cardiac catheterization section was revised to account for the new codes and provides guidance on the use of the codes in conjunction with other services. Next, let's review changes to the arterial venous fistula creation. Codes 36836 and 36837 have been added for reporting percutaneous arteriovenous or AV fistula creation. Prior to creation of these codes, CPT only had codes for an open approach to creating the AV fistula. The appropriate percutaneous code is determined by access site. If a single access site was used to create the AV fistula, then 36836 is the appropriate code to report. If two separate access sites were used, the code 36837 is appropriate to report. These codes are for the upper extremity only. If the percutaneous approach was in the lower extremity, use unlisted 37799. New introductory guidelines and several parenthetical notes have been established or revised to provide further instruction on the use of these codes. For example, the fistula maturation procedures, when performed, is included in the 36836 and 36837. Again, please refer to the CPT book for those further details. And next, we will look at T code changes related to the cardiovascular system. An add-on code was created to track when transluminal coronary lithotripsy is performed. Severe calcified plaque in coronary vessels is an indication for a coronary lithotripsy. Lithotripsy is delivered by vaporizing fluid to create an expanded bubble that generates sonic pressure waves to interact with atrial plaque, used to create fractures in the plaque, both micro and macro fractures. The guidelines and parenthetical notes provide guidance on the reporting of this code. Another new T code to call to your attention is code 0716T, Audio Detected Coronary Artery Disease Risk Score. This code represents a cardiac acoustic waveform recording with automated analysis and generation of coronary artery disease risk score. It is a non-invasive method to assess for coronary artery disease risk by placing a sensor on the patient's chest. Indications for use may be when the patient is reporting an experienced shortness of breath, fatigue, or atypical chest discomfort. Other T codes are the absolute quantification of myocardial blood flow, or AQMBF. It's an emerging technology that detects reduced coronary flow reserve, facilitates identification of patients with high-risk coronary artery disease. Other Category 3 codes for 2023 are 0744T. This code was added to report insertion of a bioprosthetic valve in the femoral vein via an open approach. It includes the duplex ultrasound for placement of the valve. The valve is single use and designed to be permanently implanted to support blood flow from the lower extremities, despite the absence of native deep venous valvular function. Indications for use are conditions such as chronic deep vein insufficiency or reflux in the deep venous system or leg ulcers. Category 3 codes 0745T, 0746T, and 0747T were added to report cardiac focal ablation utilizing radiation therapy for arrhythmia. They are used to treat arrhythmias such as ventricular tachycardia. The codes represent various aspects of focal ablation. Code 0745T focuses on obtaining the data about the arrhythmia, while 0746T is used to report when the data is converted into a treatment plan, with code 0747T describing the delivery of radiation therapy. Code 0745T is typically performed by an electrophysiologist, while 0746T and 0747T is performed by a radiation oncologist. And now it's time for our first poll question. The poll question number 1, a 58-year-old man with chronic kidney disease now requiring dialysis underwent creation of an arterial venous AV fistula in the left lower extremity. Using imaging guidance, the femoral artery and vein were accessed from the same percutaneous puncture to create the AV fistula. A maturing process occurred and the patient tolerated the procedure well. The appropriate CPT code to report is as follows. 36836, the percutaneous single access of upper extremity. 36837, percutaneous access site upper extremity, both the peripheral artery and vein. And 36831, arterial venous anastomosis, direct any site, or 37799, unlisted vascular surgery.
Okay, June, we're giving it a few more seconds and then I'll share the results.
Thank you, Jordan. And the correct answer is the unlisted vascular surgery 3779, because the AV fistula was created in the lower extremity. Had it been an upper extremity, then the correct answer would have been the 36836. So thank you, everyone, for participating. And again, the correct answer in this instance, because of it being the lower extremity, is the unlisted. And so now let's review vaccination changes. And we'll starting with COVID. Here is a review of the code structure for the SARS-CoV-2 vaccinations. There are codes for the product as shown on the left-hand side of the screen. The last two characters identify the specific product, as you can see an example in the center. The vaccine product codes are reported in addition to a corresponding administration. The administration codes have a unique format where a portion of the characters, the first to the third, correspond to the product code. Looking at the right-hand side of the screen, in the example, the 09 values correspond to the 09 values in the product code. The fourth value identifies the dose, while the alpha character of A represents administration. And the Centers for Disease Control Vaccine Administration guidelines require dosages of 1 or more injections. So let's look at changes for 2023. Codes were added to distinguish the third primary series doses and booster doses. Note all booster doses are reported with the same administration code. For example, second booster dose will have the same codes as the first booster dose. New codes were added for the pediatric populations. One new code was added to address an adult booster-only product and its administration. Two new booster vaccine products and associated vaccine administration codes were also added. As this area continues to change, not all changes made it in time for publication in the 2023 CPT book, such as codes 91315 and 0154A. Those reflect Pfizer's 5 to 11 age group. These will be in the 2024 book, but on the next slide, we will review where you can stay up to date with all the latest changes to these codes. Here's a list of various sources to stay up to date on the change at CPT COVID-related codes and changes. The Appendix Q, along with CPT Assistant newsletters available. The Appendix Q contains the product codes with the associated administration code, along with patient age appropriate for the vaccine. And as the CPT editorial panel continues to create COVID-19 vaccine codes, utilizing the tools, either the Excel spreadsheet or the Access tool, provides up-to-date information. And so next we'll look at additional vaccines. Smallpox in the United States has not occurred naturally since 1977, and the last natural outbreak in the U.S. occurred in 1949, according to the CDC. Prior to eradication, it was a serious infection with fever and progressive rash that could leave permanent scars, which could lead to other issues such as blindness, depending upon the scarring location. Monkeypox terminology is transitioning to Mpox. The CDC has adopted the new term as it aligns with the World Health Organization, or WHO's change to Mpox. During a recent NCVHS call, the change in terminology was mentioned as they transitioned from monkeypox to Mpox. And in July of this year, WHO declared Mpox as a global public health emergency. People with Mpox get a rash that may be located on or near the genitalia, anus, or could be on other areas like hands, feet, chest, face, or mouth. The rash will go through several stages, including scabbing before healing. The rash can initially look like pimples or blisters and may be painful or itchy. So new codes were added for the vaccine and laboratory testing. A few other vaccine changes are related to the respiratory syncytial virus, commonly known as RSV. Common symptoms are runny nose, decrease in appetite, cough, fever. Symptoms typically are in stages, but in very young infants, the only symptoms may be irritability and difficult breathing. Treatment is aimed at managing the symptoms such as fever and dehydration prevention. Hepatitis B revisions include addition of the 2 or 4 dose schedule, along with the inclusion of an enhancer. This enhancer helps improve protection against hepatitis B. And now we will look at pathology and laboratory changes. This will be a high-level review of pathology and laboratory changes. New guidelines for genomic sequencing procedures were added to provide further instructions on the use of the codes. New codes were added, such as 81418, which is attesting at least 6 genes that are listed here on the slide. And 81441 is performed to determine possible genetic factors for inherited bone marrow failure syndrome and includes sequencing of at least 30 specific genes. Microbiology added code 87913 for reporting the mutation identification, while new parenthetical notes were added for code 87637. We will review surgical pathology changes centered around digital pathology. Digital pathology is a dynamic image-based environment that enables the acquisition, management, and interpretation of pathology information generated from digitized glass microscope slides. The glass microscope slides are scanned by clinical staff and capture the images that are used for the digital examination for the pathologic diagnosis, distinct from the direct visualization through the microscope. Again, please refer to the book for further guidance, as you can see a list of those codes here on the slide. And briefly, the PLA tag, along with the editorial panel, reviewed 84 codes, and as you can see, those following changes here. And again, the book has the very specific information around the proprietary names and the changes to those code descriptors and the codes that were revised or deleted. Radiology saw changes to nerve ultrasound. And nerve ultrasounds provide direct visualization of a nerve to determine the presence of a disease state and to what extent, such as with entrapments like carpal tunnel. The changes created a new code 76883 for when the nerve and accompanying structures throughout its anatomical course is imaged in a single extremity. The parenthetical notes were revised to provide clarification on what is meant by a comprehensive examination, and that is documentation of the entire course of a nerve through an extremity. If the image is not comprehensive, the code 76882 was revised to reflect a focal study. Visualizing only 1 or 2 points in the extremity is still reported as the focal evaluation code for 76882. As you can see on the slide, when reporting the services, report the procedure either as comprehensive or focal, but not both. Other changes are centered around Category 3 codes, as we will see next. New Category 3 families of codes shown here are related to CT or MR, and the new codes also distinguish if the image processing is performed on a previously obtained digital imaging study or a concurrently obtained digital imaging study. Often the software is not housed at the facility performing the imaging, but rather the digital image data is sent to a third party for post-processing. The results are sent back to the facility for their reporting, and the codes for when the tissue characterization is performed retrospectively from a prior image are shown on the table, on the slide. If the tissue characterization occurs at the same time or concurrently with the imaging procedure, there are two add-on codes that are shown, the 0722T and 0724T. The quantitative CT is typically performed to characterize coronary artery calcium, while the QMRCP procedures provide quantitative metrics on the biliary tree and pancreatic ducts. Other Category 3 codes we will discuss are seen here. First, looking at the 0743T to report bone strength and fracture risk assessment using finite element analysis of functional data and bone mineral density with concurrent vertebral fracture assessment. The code 0743T can be either reported independent when performed using an existing CT or in conjunction with code 0558T when performed with a currently obtained CT scan. Two Category 3 codes 0749 and 0750T have been established for reporting bone strength and fracture risk assessment using digital X-ray radiogrammetry bone mineral density or DXR BMD analysis. Code 074T describes the DXR BMD analysis of an available appropriate digital X-ray, while code 0750T is reported if the appropriate digital X-ray is not available and a single digital X-ray of the hand is used specifically for the DXR BMD. And now we will review urology, starting with percutaneous nephrotomy. Percutaneous nephrolithotomy is removal of kidney stones from the kidney, and a pilotomy is the removal of stones from the renal pelvis when the stones cannot pass on their own. And of course, percutaneous means through the skin. The code 50080 describes the use of endoscopic instruments to break up smaller stones via a percutaneous approach. So the code description was revised to reflect current terminology used in clinical practice. The two words in green, as you can see here on the screen, are no longer used in practice. The other changes to the code descriptor, as seen here also on the screen with the strike-throughs, reflect changes to different components of the procedure that are no longer reflective of how the procedure is performed. So, and again, for additional clarification on reporting of these procedures, see the new introductory guidelines that were published in the book for 2023. Code 55867 is a new code, and it's used to report laparoscopic simple prostatectomy. Prior to creation of the code, the procedure was reported with an unlisted. Parenthetical notes were also added or revised to provide guidance for reporting this code or another code for open subtotal prostatectomy. As you can see by the prostate images on the screen, an enlarged prostate routinely creates an obstruction, causing urinary symptoms such as urgency and/or frequency. And now let's review a few Category 3 changes for 2023. Two new codes for magnetic field induction ablation of malignant prostate tissues were created. This procedure involves introduction of magnetic nanoparticles into the malignant prostate tissue. The particles are subsequently heated in an alternating magnetic field. The heat from the nanoparticles results in ablating the tissue. One code 0738T reflects the treatment planning using the data from a previously performed MRI, while the code 0739T is used to report the ablation procedure itself. And again, the parenthetical notes were added to direct accurate reporting, such as do not report 073T in conjunction with 0739T on the same data service. The last new T code we will review is 0714T for the transperineal laser ablation of benign prostatic hyperplasia. This procedure is an alternative to surgical excision, and as you can see, indications for this procedure is symptomatic benign prostatic hyperplasia. The procedure involves delivering laser energy, which heats and destroys the hyperplastic tissue. And now I would like to turn the presentation over to Shelly to continue to review other changes.
Thank you, June. Welcome, everyone. I will continue on gastroenterology. EGD with bariatric balloon. New codes 43290 and 43291. This procedure is used to assist in the treatment of conditions such as weight loss for the morbid obesity population. Code 43290 describes the procedure with deployment of intragastric bariatric balloon, and code 43291 describes the removal of intragastric bariatric balloon. This procedure is performed by putting a balloon in that fills space in the stomach, resulting in eating less for weight loss. This is a temporary fix. To provide further instruction regarding the intent and use of these new series of codes, 2 exclusionary parenthetical notes have been added. The exclusionary parenthetical notes following codes in the digestive system section have been revised to include these new codes as well. The AMA released CPT assistant guidance for these codes, which was released in November 2022 for you to reference. Next, the inhalation of biotherapeutic agent. New code 0780T added to report installation of fecal microbiota suspension via rectal enema in the GI tract. The physician instills stool from a healthy donor into the lower gastrointestinal tract of the patient via rectal enema for restoring the gut microbiome to a healthy state for those patients with inflammatory bowel disease and/or irritable bowel syndrome. No scope is involved, and there's exclusionary parenthetical following code 0780T that directs on the code appropriate to report with this code. Next, indirect bronchoscopic delivery of radiofrequency energy. New code 0781T and 0782T. These codes are performed by delivering radiofrequency for the destruction of the pulmonary nerves, a treatment known as targeted lung denervation in patients with COPD and chronic bronchitis, enabling bronchodilation to decrease chronic airway inflammation. An instructional parenthetical note following code 31661 has been added to direct users to these new codes. 0781T and 0782T may not be reported in conjunction with other bronchoscopy procedures. These codes may only be reported once, regardless of the number of treatments per bronchus. Next, non-invasive gastrointestinal myoelectrical measurement. New code 0779T is a non-invasive procedure that uses EKG leads over the abdomen that assesses motility in the GI tract from the stomach through the colon. The study may be performed over several days. Typically, this assessment is performed for GI symptoms such as gastrointestinal pain, bloating, and distension. This code includes study interpretation and report. Moving on to general surgery section. Removal of sutures or staples. New codes 15850 not new code, code 15850 has been deleted, and code 15851 revised to specify that general anesthesia or moderate sedation is required and to remove reference to other surgeon. Previously, codes 15850 and 15851 differentiated between same surgeon versus other surgeon. It was decided that this is not relevant to the suture removal. 2 new add-on codes, 15853 and 15854 were added for reporting suture removal not requiring anesthesia or sedation in the office or other outpatient site outside of the global period, with code 15853 for removal of sutures or staples, and code 15854 for removal of sutures and staples. These capture additional practice expense related to suture and staple removal not inherent to an evaluation and management code. Next, there was a big overhaul of abdominal hernia repair. New codes identify anterior abdominal hernia repairs by initial versus recurrent and incarcerated versus reducible, and by size of defect. Procedures that are performed by open laparoscopic and robotic approach are all represented in the new codes. CPT code 49568 for reporting implantation of mesh has been deleted. The work associated with mesh implantation is now incorporated in the work reported with these new codes. Hernia repair procedures performed on inguinal-femoral, peristomal, and pelvic floor hernias have their own codes and are not reported with these new codes. If inguinal, femoral, lumbar, ophallocele, or peristomal hernias are repaired at the same operative session as an anterior abdominal hernia, they may be coded separately with a modifier 59 when appropriate. A large portion of these procedures are done on the outpatient basis. These codes are to assist with being more specific, encourage you to review guidelines and parenthetical notes along with 3 new visualization tables in the AMA Professional Edition book. Abdominal hernia definitions. I've added this slide of definitions from the CPT Assistant June 2008 for your reference, as they are still valid with the new CPT codes for abdominal hernia. The next slide shows the new codes for initial specific repairs with the severity of the hernia and the size. These replace previous hernia codes. The next slide shows a list of the new codes for recurrent with the same specificity as the initial. Next is a snapshot of the new codes indicating size and severity of the hernia and the appropriate new CPT code assigned. Repair of peristomal hernia. New code 49621, which includes both initial or recurrent and including implantation of mesh or other prosthesis reducible, and 49622 for incarcerated or strangulated. The picture shows a peristomal hernia, which is a type of abdominal hernia that appears near a stoma, such as a colostomy. Lastly is removal of non-infected mesh add-on code, to be used if performed at the time of initial or recurrent abdominal hernia repair or peristomal repair, paying attention to the words non-infected. Moving on to ophthalmology. Transluminal dilation aqueous codes 66174 and 66175 have been revised to include the term canaloplasty as an example prefaced with EG. The use of EG indicates several procedures may complete the same work and when methodologies will change over time as the technology changes. This revision now aligns with the U.S. Food and Drug Administration terminology for the approved form of transluminal dilation of aqueous outflow canal. Next is quantitative pupillometry services. New code 95919 describes the quantitative pupillometry performed unilaterally or bilaterally. This includes the work involved in the interpretation and generation of a report. This code has been structurally placed in the CPT code set to precede code 95921, which involves the rapid, non-invasive measurement of autonomic nervous system function. Previously, this service has been reported with unlisted code 95999. Cross-reference note revision at codes 0338 and 0339T, directing users to this new code. Trabeculotomy New code 0730T has been added to describe a laser trabeotomy that is directed by optical coherence tomography guidance. This laser procedure is without incision. Therefore, the code descriptor does not include the terms ava interna or ava externa used for incisional surgeries. There is an exclusionary parenthetical note following code 0730T that restricts the reporting of code 0730T with other trabeotomy procedures, such as trabeculoplasty or OCT technology. Next is corneal collagen cross-linking revised code 0402T. This revision clarifies that removal of the corneal epithelial is included when performed. The phrase report medication separately has been removed from the code descriptor and placed as a new parenthetical. Moving on to otolaryngology, ear osteointegrated implant revision codes. These codes were revised 69726 to include entire, along with 69727 to include entire implant, along with additional context within the mastoid and or involving a boning defect, along with the size and surface area of bone deep to the outer cranial cortex. Added, in addition, an instructional parenthetical note following code 69726 was established to direct users how to report the partial removal of an implant, use appropriate evaluation and management code. Here is a documentation checklist for the use of the revised codes 69726 and 69727, including the addition to those descriptions. Ear osteointegrated implant new codes specify implantation, replacement, and removal along with transcutaneous. These new codes were established to more accurately describe the intrasurface work involved in magnetic transcutaneous osteointegrated implantations performed within and outside the mastoid. Making note of distinction was made based on location, inside or outside of mastoid, amount of bone removed, and they mirror implantation, replacement, and removal codes. These procedures are more work and more complex. Moving on to the vestibular device new codes. There was no specific code to report this procedure, so code 69949, unlisted procedure inner ear, was used. However, this code did not provide specific information regarding the procedure. The new codes specify implantation, removal and replacement of the vestibular device, along with two codes for the diagnostic analysis of a vestibular implant, including initial and subsequent programming performed postoperatively on a previously placed device. The physician implants a vestibular device for the treatment of bilateral vestibular hypofunction or loss. Vestibular implant has a different intended use than cochlear implant. Vestibular implant is designed to restore motion detection by providing electrical stimulation in the labor, whereas the cochlear implant is designed to produce auditory sensations by providing electric stimulation in the cochlea. A cross-reference parenthetical note following code 69930, cochlear device implantation with or without mastoidectomy, has been added to direct users to code 0725T for implantation of vestibular device. Next is the repair nasal valve prolapse revision code. Code 30468, parenthetical note directing for repair of nasal vestibular stenosis or collapse without cartilage graft, is use unlisted code 30999. New code 3469 for repair of nasal valve collapse with low energy radio frequency. This procedure has been performed since 2017 with increasing frequency that is indicative of clinical need. This new code reflects physician work required to perform the standalone procedure. In addition to repair of nasal valve collapse, here is a comparison of the codes 30465 and 30468 to the new code 30469. As you can see, code 30465 is an open procedure, and the physician work in code 30465 is different than the work and resources reflected in code 30469. Code 30468 is minimally invasive and requires an implant and employs different mechanism of nasal valve correction than code 30469. Moving into the emerging technology is an area that the AMA has added quite a few new category 3 codes. We'll start with transcutaneous magnetic stimulation of peripheral nerve. These new codes are used to report use of proprietary electromagnetic stimulator delivering pain management for reoccurring nerve pain, such as that caused by amputation, localization, burn, or postoperative pain following invasive procedures are just a few examples. All codes include identification and marking of the injured nerve and treatment location, as well as non-invasive nerve conduction, localization when performed. Now we move on to new codes for musculoskeletal. Codes 0717T and 0718T have been added for Oedipus-derived regenerative cells, which are an alternative source of autologous somatic stem cells for the repair of damaged tissue. Subcutaneous Oedipus tissue are harvested from the patient by ordinary liposuction technique, isolated the ADRC from the fat tissue, washed and filtered. This final product is injected into the targeted site, which stimulates the repair and regeneration of damaged tissue. These codes specify site of the injection. New codes for gastrointestinal procedures, 0736T has been added to report colonic lavage. Code 0736T is intended to describe a gravity-fed colonic lavage with induced defecation using 35 or more liters of water. The service is typically performed by clinical staff under physician supervision. Colonic lavage is being used as another option for colon cleanse for procedures like colonoscopy when the patient cannot or does not want to use barium enema. 0748T, stem cell therapy, and a minimally invasive procedure to treat perianal inflammation caused by Crohn's disease. After debriding and/or excising the fistula tract and surrounding areas, stem cells harvested from bone marrow or fat tissue are injected around the tissue. These stem cells have secreting factors called cytokines, which have anti-inflammatory properties and recruit immune cells needed to repair injured tissue. See parenthetical notes for codes to report along with these codes. They're to be reported once per session and report stem cells separately. Now let's go to our poll question number 2. What is the CPT code for a patient who has mesh removed from a previous abdominal hernia that is not documented as infected? A, 49263, removal of total or near total non-infected mesh or other prosthesis at the time of initial or recurrent anterior abdominal hernia repair or peristomal hernia repair, any approach. Or B, 11008, removal of prosthetic material or mesh abdominal wall for injection. Or C, 10121, incision and removal of foreign body subcutaneous tissue complicated. Jordan, if you want to go ahead and initiate the poll.
Giving it a few more seconds, Shelly, and then I'll close it out.
And that's awesome. The answer to the whole question is A, 49623, as the mesh removed and was documented as not infected. So this is the appropriate code to report for this procedure. Moving on to digital medicine to include telehealth, AI, and remote monitoring. Remote therapeutic activity revised codes. 0733T was revised to include supply and technical support, motion capture-based therapy that may include interactive computer games, video gesture control software, and/or 3D virtual gaming system, along with treatment services per 30 days. 0734T was revised to include treatment management services per calendar month. For these procedures, patients wear motion sensors and utilize virtual reality and devices to perform targeted functional activities designed by the physical therapist using gesture control. The patient's performance data uploads to a web portal upon completion for additional evaluation. New AI procedure codes include 0731T, facial phenotype refers to facial traits. The patient's facial phenotype is compared with a database of rare disease patient facial images to potentially identify a genetic cause of a patient's symptoms. Creation of a report is included with this code. 0740T, AI insulin titration. A provider uploads the algorithm-based insulin dose calculation and titration recommendations to the patient's smart device and configures the system based upon individual patient history. 0741T, provision of software, data collection, transmission, and storage each 30 days. Parenthetical note, do not report 0741T for data collection less than 16 days. New add-on code 0764T, assistive algorithmic electrocardiogram risk-based assessment for cardiac dysfunction related to concurrently performed electrocardiogram. Parenthetical note, use 0764T only once for each unique concurrently performed electrocardiogram tracing. 0765T, related to previously performed electrocardiogram. The proprietary AI-built algorithms use ECG data to detect signs of cardiovascular dysfunction that might otherwise be missed by human providers. Parenthetical note, use 0765T only once for each unique previously performed electrocardiogram tracing. New add-on code 0777T, real-time pressure sensing epidural guidance system. The sensor interprets epidural pressures and details anatomical needle placement, measurement precise saline volume via software facilitating data transmission to an epidural system console screen. Next is virtual reality. New add-on code 0770T. Virtual reality technology can be integrated into several patient therapy modalities as an adjunct therapy and is used to enhance the training or teaching of a therapy-focused skill. This code is to be reported in addition to the code for primary therapy. Do not report more than once per session. Typically used for skill building and social communication, emotional regulation, and/or daily function. Reference the parenthetical notes of the codes that can be used in conjunction with this code. Virtual reality procedural disassociation. New codes is a state of altered consciousness that supports and optimizes patient comfort, increases procedural tolerance, and decreases the patient's pain during the associated procedure. VR procedural disassociation establishes a computer-generated audio, visual, and proprioceptive immersed environment in which patients respond purposefully to verbal commands and stimuli, either alone or occupied by light tactical stimulation. VR procedural disassociation does not involve interventions to maintain cardiovascular function, patent airway, or spontaneous ventilation. These codes are not used to report administration of medications for pain control, minimal sedation, moderate sedation, deep sedation, or monitored anesthesia care. VR procedural disassociation is not, involve interventions to VR procedural is not reported for patients younger than 5 years of age. It requires monitoring patient response to the VR procedural disassociation, including periodic assessment of the patient, monitoring of the procedural tolerance, oxygen saturation, heart rate, pain, neurological status, and global anxiety, and altering of and/or adjustment of the VR program to optimize the disassociated state based on patient tolerance of the associated. Pre-service work and time are not reported separately and include the initial ordering and selecting of the VR program, describing VR procedural disassociation to the patient and/or family, and applying the VR device to the patient prior to starting the procedure. Post-service work and time is not reported separately and begins with the end of the procedure, the termination of the VR technology, and when the physician or other qualified healthcare professional is no longer continuously face-to-face with the patient. Moving on to Appendix S for AI taxonomy. This taxonomy provides guidance for classifying various artificial intelligence applications for medical services and procedures into one of these three categories: assistive, augmentative, and autonomous. The AI taxonomy provides and defines distinct categories to describe the work done by the machine on behalf of the physician based on technical features and performance of emerging AI products and services, effect on the work of the physician or other qualified healthcare professional, and discrete components of work in order to facilitate valuation. Goals of the Appendix S is to establish foundational definitions, define elements of differentiation, and understood by stakeholders that are not AI experts. Lastly, in this section, Appendix P and Appendix T. Looking at Appendix P is a list of CPT codes that describe services that are typically performed face-to-face, but may be rendered via a real-time interactive audio and video telecommunications system, identified throughout the code set with the telemedicine star symbol. Codes added this year were services that have been included in telemedicine coverage policies of at least one payer. An example code is 92603, diagnostic analysis of cochlear implant age 7 or older with programming. Appendix T was accepted at the February 2022 CPT editorial panel meeting. Identified throughout the CPT codes with the speaker symbol, listing is a summary of CPT codes that may be used for reporting audio-only services when appended with modifier 93 for audio-only telemedicine. Procedures on this list involve electronic communication using interactive telecommunication equipment that includes audio. Synchronous telemedicine services is defined as a real-time interaction between a physician and/or qualified healthcare professional and patient who's located away at a distant site from the physician or other qualified healthcare professional. An example code is 97802 through 97804, medical nutrition therapy. Lastly is our evaluation and management. Here is an overview. The AMA fulfilled the 2021 promise of making changes to other E&M codes in 2023 around medical decision-making and total time. These are the areas that have been impacted by these changes. And since we are short on time and over, this is a high level. So E&M guideline changes summarized. One of the biggest changes is consolidating all guidelines for codes that used history, examination, and medical decision-making as the three key components into one. These guidelines now provide the following modifications to address other code families: definitions, initial and subsequent, moved instructions for level selection and tables, added parental control substances, removed clinical examples, created 2 new condition types: acute uncomplicated illness or injury requiring hospital inpatient or observation level of care, and stable acute illness, modified chronic condition exacerbation at the moderate level, and reinforced independent historian services do not include translation and management or documentation subtendalities risk level. E&M services summarized. All codes that used history, examination, and medical decision-making now use medical decision-making or time, total time on the date of the encounter. The combined observation and inpatient codes, these are now a part of one subsection. Important to note the use of or in the code descriptor and all of the codes to indicate that they may be reported for either type of patient status. Emergency department is the lowest level used when patient doesn't need to see a doctor. Assisted living and other facilities combined with home residence. Prolonged services, inpatient versus outpatient use with highest time. Updated times for all codes, and allowed reporting for more than one E&M service when patient changes site. Encourage everyone to reference pages 8 through 9 of the AMA CPT Professional Edition book for full details on the medical decision table that has been updated. Here's a summary of the observation care deleted codes and new codes. And the hospital inpatient services and observation care services guidelines have been added 3 key refining criteria for these codes regarding who may report. Language specifically extending the definition of first encounter to incorporate observation status, including admitting physician language, has been removed, and criteria relating to physician in the same specialty or subspecialty and group practice affiliation has been added. Observation care services incorporated throughout all code descriptions. New codes restructured to model outpatient office codes. Total time revisions for 2023 have been updated for all these new code descriptions, and I encourage you all to read through all these updates. This concludes my portion of the presentation. I appreciate all of you attending. Now let's move on to Q&A.
Awesome. All right, so we'll be kicking off our live Q&A. Obviously, it is past 1 p.m. Central, so if you need to jump, that's okay. We will send you a recording along with your certificate of attendance, but in the meantime, if you have any questions, type them into the Q&A box. Just please excuse any brief silence while our presenters will look over them. The recording will be sent to people after the webinar, along with the copy of the slide deck, by the way. All right, this question is for Shelly. For the 2023 CPT guidelines, are they looking at adjustments to the PE or mostly time and MDM to calculate codes?
I am so sorry. I was reading this question and answering it, and I was on mute. I'm so sorry.
You're okay.
They actually are not adjusting the physical exam. It is only the total time and medical decision making to calculate those codes.
All right, it looks like we have a quiet bunch today, so we're going to go ahead and close out. We hope you found today's information valuable and useful. Shelly and June, awesome job. I know you need to go suck on some cough drops or something like that after all the speaking. But if you have any questions regarding technical support or content questions, please contact customer support at imohealth.com. If you have any questions regarding our IMO solutions or anything more about IMO, contact sales@imohealth.com. Thanks so much for attending, and I hope you have a great rest of your day.